Ready? Please start.
I'm ready. You so do only you have to say me start and I put my
Okay.
chronometer too.
So please start.
Okay. So hello everyone. I'm Dr. Pablo Urrutia for MEGA'MIND Content today. So the topic that we are talking today is about management of surgical complication in the aesthetic zone. So this is the story of a patient of me. Anthony is a very interesting case, a social case that a colleague referred to me 2 years ago. So you can see the huge defect and 3 failed surgery. It's a 26-year-old patient with no comorbidity, incisor pattern, and 3 failed attempts of surgeries. So the situation and the protocol that we use always to face this challenge is the site management, vertical GVR, implant placement, soft tissue, prosthesis, and maintenance phase. Okay, so to begin with, it's site management for me is very important in the selection of the patient and the proper management on hard and soft tissue. So this is colon classification and the fourth dimension that we use to select our patient. And you can see the yellow flag that in local findings, because the 3 failed surgery and the acute infection with the 3D vertical uh, resorption, okay? And the surgical because it's very challenging situation. So this is the WhatsApp image that a colleague referred to me. So the first appointment is that situation, okay? So maybe we resolve the local finding, but I always, when I extract implant or teeth, normally I do something more like soft tissue grafting or preservation or something to increase the soft tissue, preparing the flap for the surgery, the most risk surgery in terms of vertical GVR. So, okay, so now we have only a surgical attempt in terms of the difficulty of the case. And this is the colon classification again about rich defect. So we can see the different approach that we could use in this kind of situation. And we choose because the vertical and horizontal is a severe situation. We use the autologous bone with GVR with some kind of space maintenance device. Okay, so this is for us was shows for us. We have more than 10 years in vertical GVR, so we choose PTFE membrane to the vertical so the vertical GVR. So for the surgery time, it's for me very difficult to show you a complication of me. So this is the situation. You can see the nasopalatal nerve on the top of the ridge and the more than 10 millimeters vertical situation with horizontal defect too. So we use a, a large PTFE reinforced membrane with composite with 50% of autologous of bones and allogenic biomaterial, putting the membrane on position as described by Urban with 1.5 millimeters in terms surrounding the teeth with that space to promote the sealing of the soft tissue. And you can see the flap closure with tension free. Okay, but what happened 3 months later? It's a late exposure. So for me, it's a very challenging situation because how we manage that kind of exposure. So to the literature told us, Nicholas Donos says the factor affecting the GVR. So looking for what mistake we made in terms of what happened to because of what happened in that complication. So we we thought about the compliance of the patient. The comorbidity is okay. maybe the healing protocol or the surgical complication. So for me, maybe my mistake was the healing protocol. Because of what? Because before the second month, the colleague that referred the patient to me, he wanted to participate in the follow-up of the patient. So he took the patient in the second month and forward. So maybe we failed in something. Maybe he didn't see something, and maybe that was a key factor because I lost the follow of the patient from 1 month. Okay, so but as a surgeon, as a first surgeon, was my responsibility too. So I took the case again, and we see again with Nicolaus Donos about the class 2 exposure that we face. So the literature say to me that large membrane exposure more than 3 millimeters, that's a huge exposure. But the good news for me is no purulent exudate. Okay? Another good prognosis with this complication, it's because the edge of the membrane it's covered by tissue. So the handle of the tissue, it's with good prognosis. And the time, it's more than 3 months. 3 months for me, it's because we have some baby bone or bone on the road, so we can maintain some bone in that exposure. So for me, we need to, if we fail, so we need to rise again. So I need to put my chin up and face the patient, face the situation, and have some responsibility and do something for the good of the patient. So we talk with the patient that we need to remove the membrane. So we remove the membrane, exposure the entire flap again. We see a horizontal gain, and we do something new. So we call this kind of management to promote the healing. Okay, so we use two approach in terms of the soft tissue to increase the healing on the top. So as you see in the picture, this is horizontal gain, but more important to us is what I call in this situation. This is a two rotated palatal crossed flap. Okay, this is an innovation. I didn't see in the literature, so that was my invention in the surgery because I was struggling with the closure of the flap. So we use this approach to promote the healing, increase the height and soft tissue, to promote the closure of the exposure, increasing the thickness of the flap and increase the vascularity. Okay, so you can see in the picture the closure of the flap, and you can see the healing, how the tissue was growing again. Okay, now we have maybe not a very good situation, but we are better than the initial case. Okay, so maybe take some risk in this situation to promote another bone gain. So the lesson for me, if you keep doing the same thing again, then you can't expect different result. So what the situation here, if we try another PTFE membrane, we risk again another exposure. So we need to lower the rate of exposure or complication. So you can see in this in vertical dimension, and in the previous picture, and horizontal for the entire rehabilitation, but we use these devices, the TI mesh and the collagen membrane, with the principle of Dr. Humbly Wang: primary wound coverage, angiogenesis, space creation, and stability of the wound. Okay, so we put the TI mesh on the palatal aspect with 2 millimeter gap that we fill with autologous bone, and we put the implant in the 3D position outside of the contour in the supracrestally approach, but in the exact position that we need to have the proper rehabilitation. But you can see in the picture how the TI mesh create the space, okay? Because the collagen membrane doesn't have the property to maintain the space. So with the approach of a sausage technique described by Urban, we use what I call the sausage 3.0 because we use the TI mesh only in the palatal aspect to give the membrane the support of the palatal and do more vertical gain, and the sausage with allogenic mineralized biomaterial with 50 to 60% of autologous bone. So now we have a proper closure with a good healing. So we don't have any exposure or healing or that healing process. So you can see in the CBCT how we gain the entire palatal aspect bone wall in the control CBCT and the horizontal gain, and the entire implant is surrounded by bone. Okay, so now we resolve the complication, we put the implant, and we gain in the vertical aspect the bone. So now we need to have more soft tissue. So in the soft tissue management, I have to keep in mind that we need the vertical and the vestibular aspect to have the proper aesthetic. So we do what Zucchelli described it as a soft tissue platform. So we use this approach to gain more vestibular depth, made some musculectomy, put the graft on the vestibular aspect, and give and a platform of the soft tissue with connective tissue, put another connective tissue on the top, and closer with the mucosa. You can see this is a very complex case, but give me the soft tissue in order to gain volume and height of the soft tissue to have the prosthetic face in order. So now we have the hard tissue and the soft tissue, but we need to mobilize and need to give the situation the proper aesthetic. Okay, now this is the before and after, and you can see in the huge gain in terms of hard and soft tissue. So now this is the prosthetic face. In the prosthetic face, we use what my friend Jonathan Esquivel, the 3-position, the bone grafting and connective tissue, and long-term provisionalization. So we use this article to give the delayed implant placement with no fixed provisionalization. We need to wait 6 to 12 months to have the provisionalization that we need. So before the 6th month, we have this emerge profile. We use this TI-based abutment, and you can see the 1-year follow-up before the provisionalization, and you can see the before and after 2 years of the patient of the delivery. So now this is the situation. Now in the control, you can see the bone, the TI mesh, the proper rehabilitation with a good space, and this is the 2 years of follow-up. Okay, now this is the situation, and we gain soft tissue, hard tissue, papilla, and the proper rehabilitation of the patient. Now, this is a challenging situation. We took some time. It's very difficult if we have this very hard situation, but with the technique that we used, with a good predictability, with evidence support and comfort for the patient, and the proper aesthetic for the patient. So now, to keep in mind what we use always in this protocol, we need to gain these 5 principles: sufficient bone contour, soft tissue thickness, soft tissue height, keratinized mucosa, and sufficient prosthetic space. And what is the lesson learned from this situation? Always in the extraction and the preparation of the patient, do something. The palatal approach for me is mandatory for the closure of the flap. Always double check your surgeries, and the HITL protocol is mandatory because something could happen in the 9th month of waiting for your bone. So this is to keep in mind the lesson learned and the message about our protocol in this kind of situation: the site management, vertical GVR, implant placement, soft tissue, and the prosthetic face. And what about the complication? Normally, we have knowledge, and with experience, we can do some creativity, because always the techniques is ruled by principles. And those principles we need to management when we are struggle with some situation. Okay, so thank you. Hope you enjoyed my case, and thank you very much. 15 minutes.
Recording stopped.
15 minutes, 5 seconds.
Thank you for your presentation.
Okay.
So the judges, any comments?
So thank you for your very interesting presentation, and you have the good result, excellent results comparing from the beginning. So I'd like to ask, you got the GBR, the bone graft twice, and you did the implant placement after the first augmentation. And so what do you think about the stage of implant placement? Like you place in the middle between two GBR, or you want to, like, is it better to did the augmentation completely before implant placement? So what is your idea of that?
Yeah, well, the situation here, it's because I always talk to my patient that we have this stage about the GBR and then the implant placement. But because it's a social case, with a very good patient, sometimes we take some risk for the benefit of the patient to shorten the time of the waiting. So maybe with a low risk attempt could be perform the entire GBR and then put the implants with the proper bone. But this case, we train with Juan Alberto Fernandez from Spain, Ramon Gomez Meda, and we have some experience in terms of vertical GBR and those principles. So to gain 2 millimeters in height of the vertical aspect in my GBR, for me, it's very easy. So to put those implants in supracrestal approach and gain 2 millimeters, it's not a huge challenge. So for the benefits of the patient, and I see the topics of the evaluation, so maybe this case have some impact and clinical impact in terms of what we manage in terms of the risk and the impact of the case in terms of innovation, because perform the both situation in terms of both situation, implant placement, vertical GBR with implant placement could be it's not always the situation. It's not always I don't know how to say it. Let me check. Maybe it's risky, but there is no some evidence in terms. But when you are expert, you can maybe think outside the box and do something new for the patient. Okay, so that's the reason what we do, and we take this risk. Maybe for the patient, because we need to gain that we lost in the first attempt. So the second attempt for me was more challenging, because we need to gain the bone that we lost and put the implants and do something more.
Okay, thank you. So do you mean that, like, you make the implant like tenting for the second bone graft?
Yeah. I don't put the picture, but I put always a healing, 2 millimeter healing to gain more height of the patient.
Yeah.
So the TI mesh, it's the support of the collagen membrane, and then the 2 millimeter healing in the implant help me to gain more bone in the height in the vertical aspect. So that's the reason we did for the patient.
Thank you.
All right, congratulations, Dr. Urrutia, for this beautiful, management and beautiful photos, documentations, and the flow. So You as periodontist, I'm going to ask a little bit non-surgical question. So this is a patient, 26 years old, with the reason for the tooth loss of periodontitis, incisal-molar situation. For this kind of young patient, how do you communicate with them regarding the long-term maintenance and the potential long-term situation if they are receiving this dental implant treatment in aesthetics? Thank you very much.
Okay, so for me, it's always a 60-minute talk in the beginning of the selection of the patient. So when we start the situation, I'm a periodontic too. So we talk with the patient about the periodontitis, the need for maintenance. Because he is very young, so the proper maintenance of this kind of situation with the patient, it's always with 6 months of control of the crown and 3 months of periodontal maintenance. So we, to the start of the case, we always have this kind of talk with the patient because in the long-term stability, it's the mandatory with the risk of the periodontitis, for example, and the risk of, because we have to maintain this peri-implant status with maybe 20 years. So the patient have to recall every 3 months to my dental practice, and this is the compromise of the patient.
Thank you very much.
Okay, thank you for today. The result. You have 15 minutes, so you are ready. Please start.
Okay. Uh, uh, Good afternoon and good morning. I am Andrés Acevedo from Venezuela. Thanks to the MEGA'MIND team for promoting activities of this level and for the opportunity to make me part of the MEGA'MIND event. The topic I will present is relationship between immediate implantation in the posterior area and use of anatomical healing impact on peri-implant tissues case series. In this image, we observe ideal condition of the peri-implant tissue. It has been shown in the literature that the quantity and quality of soft tissues is essential for the stability of the peri-implant bone crest and the heal of the implants. However, to reach this condition, there are factors to take into account. The first factor is that we start with a bad situation, a thought that need to be extracted, a missing thought. Reviewing the literature, there are stories that report the high prevalence of people with lost teeth. There have been multiple causes related with this problem and also reports to have effective treatment. In 2022, Vizcaíno published a study that they did in 10 countries in Latin America and found that 63% have some type of edentulins. It's a very high number. This really is a problem for people. So, what do we do? The immediate placement of a dental implant is a predictable treatment. Many clinicians focus their attention on the aesthetic anterior area, but we know with the importance of the properly treating the posterior area. It has always been a particular challenge with the anatomical complexity and functional demands of this zone. There is scientific evidence that support the immediate placement of implants in the posterior area. In the Tarnow and Smith classification in 2013, we find treatment guidelines depending on the different clinical situation, having alveolus types A, B, and C according to the case. The objective of this work is to present a series of clinical cases with a flow illustrating the relationship between the immediate placement of the implant in the posterior sector and the use of anatomical healing and its impact on the peri-implant tissues. The methodology consisted of presenting a series of cases with clinical and radiographic sequence, performing immediate extraction and placement of the implant with anatomical healing, and evaluating the impact it may have on the peri-implant tissues. All cases were done with the same protocol using MEGA'MIND Anyone system. All patients approved consent for procedures and documentation. All cases were analyzed with a CBCT for diagnosis and treatment plan. Let's see the case. Case number 1, lower first molar. Important in all cases, a clinical and radiographic sequence of the surgery and final restoration was made. Digital flow was included. In this case, the complete sequence is shown. However, due to time constraint, not all cases will be shown in such detail, but the flow is what the same in all of them. We observe radiographics and clinical flow where an immediate implant is made anatomical healing placement, then there is an evolution of the restoration with digital flow, taking care of every detail. and the impact it has on the soft tissues is evident. Case 2, second case is a second premolar where the flow was performed, extraction and drilling, implant, bone graft, and anatomical healing, osseointegration, and restoration. Case number 3, case with another second premolar with the same flow, extraction and drilling, implant, bone graft, and anatomical healing, osseointegration, and final restoration. Sequence, radiographic, and clinical. Case 4. In the fourth case, we apply the treatment to the upper first molar. We can observe the good response of the tissues is good. And the number 5, in the last case, we perform the surgical and prosthetic flow in the same way on an upper second premolar. It's important to mention that all immediate implants had adequate seating torque to place healing abutment. Let's discuss the topic. The 3D position of the implant is very important. We have to keep in mind 4 orientation planes: diff, body, inclination, and interproximal. The diff of the implant is vital to optimize the soft tissues. An implant with inadequate diff and insufficient soft tissue will prevent the ideal management of the emergency profile and may compromise the restoration. The ideal is to have minimum 4 millimeters from the implant platform to the gingival margin. There are factors that can determine, such as the prosthesis connection, the type of restoration, peri-implant phenotype, and other important factors. Based in literature in 2022, Ramon Gomez Meda, Jonathan Esquivel, and Marcus Blatz published the article that has had the most citation in the last 2 years in the world, talking about those areas that must be respected to have ideal peri-implant tissues. 3 zones were defined from the implant platform. The first is the crestal zone, and measure is 1 to 2 millimeters, and this zone cannot change in the pillar frame to remain straight and thin. The second zone is the biological zone and goes from 1 to 1.5 millimeters. And the third is the aesthetic zone, defines the gingival contour and most measure is 1 millimeter. The sum of these areas generates a minimum and approximate distance of 4 millimeters, the necessary distance for proper tissue management. Currently, on the market, there are anatomical healing options that simplify the management of the profile, adapting to different clinical situations, respecting that shape and those measurements that Gomez-Meda talks about in the article. This kit has different healings to adapt in the zone to be worked on and guide the soft tissues. In this image, we see how the anatomical healing contains the shape and measurements for the tissue zone, some aesthetic, some biological, some crystal, in analog and radiographic. In the first case reported of this study, we observed In the scan, the contour generated by the anatomical healing, and this is transferred to the laboratory for the correct elaboration of the crown, following the contour of the tissues. Studies have shown the attraction that exists between titanium and the tissues of the body. Peri-implant tissues have a good response to anatomical titanium healings, helping stability peri-implant. In our experience, in the case reported, when doing extraction with immediate implant and using anatomical healing, we can obtain good results. That in a few steps, we obtain an emergence profile adequate for provisional or definitive restoration. The function and biology are respected, and the result is very satisfactory. We always try to imitate nature. Comparing with what we have used, it is evident that with this protocol, go more to nature and obtain great results. The conclusion to close, the use of anatomical healing is presented as a viable and effective alternative during immediate implant placement in the posterior sector, offering advantage in terms of reduced trauma, tissue preservation, prosthetic measurement, improved aesthetic, and keep peri-implant healed. The stability of peri-implant tissue is beneficially impacted with the use of anatomic healing. More studies need to be conducted to obtain more evidence and support. We continue to extend this research, and in addition to what is shown, we are also studying the histology and histomorphometrics of peri-implant tissues with the use of anatomical and conventional healing. We have found histological difference in tissue composition that can help us with selection of the ideal healing for obtaining better results. We will continue with this research. We want to have the opportunity to present them together with the great MEGA'MIND family in Cannes, France. It's an honor to be part of MEGA'MIND. Thanks for your attention.
Recording stopped.
Please let Dr. G start the questions first.
Wow, congratulations, Dr. Acevedo. This is a very nice presentation, very important in my opinion. In the last few slides, you showed the histological evidence about the advantage of using the anatomical customized healing abutment. Okay, could you elaborate a tiny little bit more about how you perform that? Is it based on human beings, animals, or yes, if you could, thank you.
Okay, thank you for your presentation. Oh, sorry.
Huh?
Sorry.
Yeah. Okay. Repeat, please. Repeat, please.
Okay. Yes, congratulations on the presentation. Very nice one.
Yeah.
So you showed the histological findings. Can you elaborate a little bit more? Is it human versus animals, and how did you do it? Just quickly, if you can. Thank you.
This story was based in humans, and we did this pilot story because it caught our attention that when we observed, we had differences and they wanted to do histology. But we need more time to have results. We are doing the story at the University of Santa Maria in Caracas, Venezuela. The bioethics committee is doing the analysis for its approval.
Thank you.
Okay, thank you for your If you are ready, please start.
Okay, hello, good evening for everyone. My name is Valentina Rodriguez, and I'm prosthodontic. I study in Colombia in the Pontifical Javeriana University. And today I'm going to talk about the full upper arch rehabilitation with an all-over technique. So as an introduction, it's important to talk a little bit about the upper arch rehabilitation. It's important to know that the physics rehabilitation is the best option in these patients because we have we have some improvement like the comfort, the substantial improvement in the prosthetic function, the adaptation, and the stability. This is really important because it's going to be a lot of benefits for our patients. But we also can have some challenge in this situation. We can have a loss of the alveolar bone, specifically in the posterior region. So that's why the all-on-four technique or concept was developed. The all-on-four concept consists in the placement of two anterior implants in a straight position and two distal implants with angulations between 35 and 45 degrees. Okay, how can we see there in the pictures? It's important because this all-on-four technique have an advance that we can make an immediate prosthesis after the surgery, and then we can use these prostheses until we can start making the finished restoration. So we also have to know that in this situation, we have to be really, really careful with the cantilever length, because because of the number of the implant, that is going to be only 4 implants, we can have higher stress in the implant and in the product. So that's why we have to make a short rehabilitation or a short arch rehabilitation. Okay. It's important to know that the implant survival rate is between 98% in the upper arch and 98.1% in the lower arch after 4 to 10 years follow up. We also have in another studies the implant survival rate of 94.7% between 5 to 13 years, and in the upper arch, and in the lower arch we have 93% between 10 to 18 years. Okay, in the lower arch. We also have to know what shows the studies between the immediate and the delayed loading. So the study shows a 10 years survival rate of 93.3% for immediate loading, and 94.9% for delayed loading. So this is this introduction is a standpoint for our clinical case. So here we can see a 51-year-old male that doesn't have any systematic compromisions, is not taking any medication. In the clinical examinations, you can see an edentulous upper arch. You also can see a decrease in the vertical dimension and in the lip support. This is our workflow. We start making the total prosthesis in the upper arch. Then we took a CT scan of the patient with the prosthesis, and then only the prosthesis. Then we start planning everything, all the implant placement with the CT scan and everything, and all the information that we collect. And then we made the surgical guide. Here we also can see the step of the surgery. So we start placing the surgical guide, then we place the implant and the multi-unit abutments, and then we capture the immediate process. Now I'm going to show you a little bit more specific all these steps, okay? So here you can see the CT scan. You can see how our work team planned everything. You can see the position of the implant are distributed according to the prosthesis mark and the bone and the bone that our patient have in this mask. Okay. Then we start. Here you can also see the materials and some instruments that we use. You can see that we use any1 internal connection MEGA'MIND implants. Here you can see the surgical guide, and we also use the MEX torque. So now we're gonna talk a little bit about the surgery steps, okay? And in the first steps, we place the surgical guide, how you can see here in the pictures. Then we start our surgery. We start, here you can see how we place we place the guide, then how we start doing all the holes for the implants. And here you can see the placement of the implants with the surgical guide. Okay, now then we took out the surgical guide and we start to place the multi-unit abutment. Here you can see how we place the multi-unit and the parallelism between them. And for the last step, we capture the immediate purpose. Here you can see a CT scan after the surgery. You can see the placement of the implant and the bone around them. And here we have like the steps for capturing the immediate prosthesis. So we place the temporary cylinder in the multi-units. Then we start trying in the position of the prosthesis to be sure that all the aesthetics and everything is what's fine with the patient. And then here you can see also how we cut the prosthesis, because we don't want like a high cantilever, a length cantilever. And then you can see the final result of the immediate prosthesis in the patient. You can see how he's smiling, how happy he is because of the result. So now, until the healing process is happening, we start to plan how we're going to do our final restoration. Okay, so we start making a really carefully research about all the options that we have for this final restoration. For this case, we start like planning, or for us to start planning, we have to be sure how is the space that we have between the upper and the lower maxillary. Okay, because as we know, any restoration or to really select some restoration, we need to know if we have to replace some gum with ceramic or not. So our patient is between or has between 14 millimeters between the upper and the lower maxillary. So we decide to do a CAD/CAM titanium acrylic prosthesis. Okay, so in our research, we found that in 5 years the prosthesis survival. Okay, in 5 and 10 years, we can see the prosthesis survival rate between 82% to 100%. So for us was a really good found. So we just decide to start doing our final restoration with this technique. Okay. Here we can see how was the final restoration. So here you can see our try in wax, just to be sure and to see all the aesthetics of the patients. And then here you can see our final restoration. We also made a guard for protection in the night during the sleeping time. And here you can see our patient. I'm sorry. With the final restoration. Okay, here we can see the before and after. We can see all the changes. Here we can see that we like increase the vertical dimension that the patient lost. We also have the lead support, the lip support that is really important in these cases. Here you can see the changes in in a front view, you can see the smile of the patient and all the aesthetics criteria that we. So for a conclusion, after seeing all our case, we can conclude that the fixed restoration are the better option for this type of patients, because as we see, I mean, that we can have a change in an immediately change is a really important thing for our patients, and that we can make immediate prosthesis while the healing process is really I think is really important in our results. And also it's a significant advance that we with this prosthesis that we can have a success rate of the CAD/CAM technology that typical range well above the 90% over a period of several years. Obviously, we have to be very careful with the care and maintain. Thank you very much for your attention.
Thank you very much.
Recording stopped.
So thank you very much for your presentations. You got a very nice result. So I would like to ask you, what is your option of using 4 implants or 6 implants, or even like doing an overdenture, like place just 2 implants for the overdenture? So what is your comment or your idea about this, about the selection?
Okay, sorry. Just to be sure, you are talking about how I like select if I'm gonna put only 4 implant or 6 implant, or if I'm just gonna do a overdenture and just Okay. I mean, it all depends in the bone condition of the patient. Okay, so in my opinion and in my career, I have like the experience with only 4 implants, and I have a really good result. So for now, I think if the patient is gonna need, or is it's gonna need something like really fixed rehabilitation, I prefer to put only 4 implants, because that's the experience that I have. Okay, but we can see also in the study that the all-on-6 is also really well in these cases. So I'm just talking about my experience, but yeah, both of them, we can see in the study that both of them are really good for these patients. And for the overdenture, it depends really in what the patients want and the economical how the economical if the patient have the economical position that we can start working with more implants or just with 2 implants. So it depends really in what the patient wants, I think, because all of them we can see in the studies that they work well.
Thank you very much.
Okay, thank you for your presentation. So the speakers are waiting. So So now you have 15 minutes. If you are ready, please start.
Where do I press start? All right, just go ahead and talk.
Yep.
Okay. All right. Well, thank you. My name is Danny Domingue. I'm a general dentist in Lafayette, Louisiana. My lecture's on top tech for full arch. On social media, I'm an implant diplomat and Louisiana Dental Implant Lab. Louisiana Dental Implant Lab was the lab that I used for all the provisional and final prosthesis for this case. They actually developed the Vortex full arch screw for angulated screw channels. So I do have financial interest because I'm a dental practice as a general dentist 50-50 with my uncle. I lecture a good bit on as digital dental masters. Own and run the lab, Louisiana Dental Implant Lab, create the Vortex screw, and we'll talk a little bit about the Smile Mission Foundation towards the end of this. This is a typical case. We're going to jump right into it. You know, a patient came in, she's got a failing maxillary dentition. She's got advanced bone loss in the maxillary arch. She's got minimal tooth in the upper arch. She's got a little bit of pain. She doesn't have a lot of function, and she wants her smile back. And you know, on the mandibular, the lower 23 through 26 are failing, and she's got decent teeth, canines and bicuspids. But for her, she was referred by her general dentist for upper and lower full arch fix. And what we do with any of these cases is take a CT scan to try to figure out the bone volume or what's left, because she's got so much bone loss. Where are we going to put our implants? And so we utilize cone beam CT scan to find out where the implants and their planned positions could potentially be. And then we also take intraoral scans of the upper and lower arch, mesh these back into our CT scan to make sure that our implant plan positions are actually what we can actually perform for her and give her natural teeth. Then we'll take facial scans and mount her upper and lower arch utilizing her face, trying to get her into her correct CR position for the correct vertical dimension of occlusion. Once we have this position, we'll do a digital wax up for the upper and lower arch for our conversion. And once the surgery is performed, we'll convert our digital wax up into a 3D printable file to give her a new smile before and after. We'll deliver the provisionals next day, screw retained with the Vortex screw for full arch, and change people's smile. So this is her before and after smile. The top photo is Monday. The bottom photo is Tuesday. These are 3D printed next day delivery full arch. And you kind of see that we give her back posterior teeth. We kept her in her correct CR position, got her into a correct VDO, and gave her a full complement of teeth, and actually completely changed the way she looks and gave her back her smile. In fact, I took the final photo, and when I went back to look at before and after, I was blown away at the results. But this is typical what you should see in cases that come in with failing dentition, knowing what the end in mind should be like. Not every case is a FP3 case. Many cases that we perform are FP1 cases, but in these particular cases, it's really important to scalp the soft tissue profile in the provisionals. Provisionals are key for cases like this because you can utilize the contours of the provisional prosthesis before you go to finals, and making sure that we have nice ovate conics sites for FP1, but not all cases are FP1 or FP3. Thinking outside the box, there are cases where people are in much different situations. This lady came in, she had odontogenic keratosis of the mandible, failing. She went to go see an oral surgeon. They elected to remove her entire mandible and do a fibiograft, KLS Martin reconstruction with monocortical screws and a free frap from her right leg. This completely changed her life because now she can live, but she doesn't have teeth. And so I do it all. What we do in all our cases, take a CT scan and try to find some bone volume. Now, it's very important whenever you're looking for bone in these areas, you have to keep the implants away from that KLS Martin plate. And why does she want to come see me for implants? She just had her mandible taken out, is because she's miserable. She can't eat, she can't function, and she's still married. And she said, I don't understand the meaning of life if I can't look at my. And it was sad because she thought about taking her own life, or she didn't understand the point of living without in the condition that she was currently in. And so I can help this lady, and I'm going to give her teeth back, but I'm going to do everything I can to help the implants integrate as fast as possible by removing the hydrocarbons off the surface of the implant. Increases the wettability of an implant surface, which increases the bone to implant contact and speeds up osseointegration. For example, this is what it looks like. You have a normal implant that comes straight out of the package, and we'll dip it in PRF. All right, and then we'll put that same implant in the Plasma X motion by MEGA'MIND, and you can see the wettability of the implant is dramatically increased. And all that is giving the implant plasma coating. That's all we've done, right? And so that plasma removes the hydrocarbons, increases the wettability, so you can get implants to integrate as fast as possible. And in cases like this, you need it. So we'll take a CT scan at central occlusion at the correct vertical, which we've determined by using a wax rim and base plate. Took a CT scan in this position, and now we're ready to figure out her bone volume. So we'll perform a procedure called advanced bone segmentation to take that DICOM data and turn it into an STL. All right. Once we have it into an STL form, we'll figure out our vertical plane and our horizontal plane. Once we've determined those planes, we can now create our digital wax up for the lower arch based on her facial planes. That's what this is our digital wax up. Now, once we have that, we're ready for our implant plan positions, but keep in mind though, this is not a jaw. This is not a mandible. So we're gonna have to put these implants in the correct trajectory. See, you can see the curvature of our mandible and the curvature of the teeth into the correct bite of where she needs to go. So the implants are gonna be planned as such where they're coming out the occlusal surface of the prosthesis that we're planning to put in her mouth later on. So you have to be careful with these implants because they have to be at least 3 millimeters away from that KLS Martin plate to not introduce bacteria and contaminate the plate. They also have to be placed subcrestal. You can't expose the KLS Martin plate to contaminate or bacteria because you can have failure, and we'll look at that in a second. Also, keep in mind that the platform of our implant to the CEJ of the diagnostic axis is 17 millimeters. 17 millimeters. That's not typical for a full arch fixed hybrid. So this is going to be an FP3 full arch fixed hybrid for her case. Now, I want to make a stackable guide, but you can't use lateral pin retention for a stackable guide in this type of situation because the bar is in place and it has monocortical screws on the buccal already. So the way to create a surgical guide for her is first of all, we're going to create a path of insertion for our model so that the guide is passive. Now, once our implants are highlighted, you can see those little purple things are our implants in the plan positions. I'm going to highlight that orange area is where I want to create my base guide around my implant positions, right? Once we've highlighted that, this is a free software called Mesh Mixture. We can extend this out 1 millimeter, and that'll create a digital file to create our surgical guide as our base guide. And we'll add 5 pins to that base guide. And those pins are going to use as telescopes for our secondary stackable guide. And we'll utilize monocortical screws to be able to fixate this base guide to the mandible, which I'll show you in a second. We used Tatum's monocortical screws. And this is our superstructure guide that gets seated on top of the substructure guide. And this is how it comes off and goes back down. So it's a simple base guide, superstructure guide, and all that's going to either get 3D printed or milled, but for this particular case, we're actually going to mill it. So then after that, we have our base guide, we have our superstructure guide. All we need to make is some provisional prosthesis. So this hybrid is based off of the wax up, and all we do is extend it down to the telescopes. So it's going to sit on those telescopes and be able to use that for our pickup conversion. So that's what this looks like right here. This will go up and down. That's how it seats. All right. Now that the case has been finalized, our case plan has been finalized, we're ready to manufacture the prosthetics that we made for her, or the surgical guides that we made for her. And we actually machine these on a 5-axis Aram mill that's came out of South Korea. It's a these are made out of titanium. All right, and then we'll 3D print our provisional, and we're ready for the surgeries. We'll do a full arch flip, full arch thickness and section dissection. Then we get around the KLS Martin plate. We'll do a split thickness dissection to not expose the plate. Now you can see these are all our monocortical screws. Those are going to hold our base guide in place. We'll use our superstructure, and then now we're able to drill our osteotomies through the guide. This is a very rigid guide. We'll use our Megagen AnyRidge keyless kit for this surgery, making sure that there's copious irrigation, not to overheat the bone. I'll pop that off just to make sure all the osteotomies look good, and put it back in place and placed our implants through the surgical guide. And I love this photo because it shows the accuracy of the guide and the precision of everything that we've treated and planned. So up until this point, all we do is torque out the multi-unit abutments in place, place PRF around those areas, and then do our pickup conversion with these temporary titanium cylinders. We'll seat that provisional back in place, do a cold cure pickup, chair side, just like this, polish everything off, smooth it, and deliver it. And she heals for 3 months. She goes off and heals for 3 months, comes back, and this is what she looks like. I mean, look at the smile compared to her initial smile. Now, all the tissues look good right now, except for that site number 27 where they look inflamed. It's because there's too much pressure on the tissues in this area. We'll relieve this, allow it to heal, scan everything, and then manufacture a titanium substructure, superstructure, and zirconia, screw retain full lower arch into class 1 occlusion. And this is her photos of her smile. These are the before and after transition, her before and after photos, and it's completely changed who she is. Now, the deal is the reason why these are so risky is because if it fails, you don't lose the implant, you lose the actual mandible. You can lose a whole mandible because the bacteria will get it around the framework, the KLS Martin framework, and fail everything. And they're catastrophic failures. Fortunately for her, we've been blessed. We didn't have any failures. She's 1.5 years post-op, and everything's going really well. Reminds me of a case that I did for a gentleman who actually got in a tragic accident. He actually lost his ear on the right side. So we do all these other patients. We took a digital scan of the calvarium, mapped out where the bone needed to be, took a digital scan of his left ear, superimposed it on the right side to be able to create a surgical guide, mirror image the ear, and we're able to make surgical guides to be able to place implants in the correct positions. We utilized the master array cells, grafted that. We're able to place our implant into this position, torqued out at 35 Newton centimeters, placed 3 more implants, and got primary closure. Once we got closure 3 months later, we exposed all the implants, got primary closure, and we were able to digitally reconstruct this guy's ear. Utilizing digital technology, sent this off to an anaplastologist that did a high heat injection mold technique, and we 3D printed the framework and delivered the ear, and you can see how the final result. And this is just me doing this when I've never done an ear before. As dentists, we can change people's lives and we can help other people out. And this is the way I help other patients, is trying to create ways to make full arch easier and better and give back. We're so blessed to have our jobs and do things for other people. I go on mission trips once a year and help out with the dental students from LSU School of Dentistry. This year was a little bit different because we got to actually visit an orphanage, and this baby right here, she's 7 days old. And this room is filled with orphans and cribs. And being able to go back and help these kids out and do dentistry for them for free was a blessing. And I'm thankful and grateful for being able to be a dentist, being here today, and help being involved with Megagen. I'm thankful for the career that I have. I'm thankful for giving back, and I think we all should have that. And what we do for our living is a blessing, and we should all consider what we do for other people is amazing. Thank you for this opportunity. Thank you, Megagen. Thank you to the judges. I wish you guys all the best of luck, and I appreciate the opportunity.
Recording stopped.
Thank you for your presentation. So the judges, any comments?
Thank you.
Wow, amazing. This is eye-opening to me. Congratulations. Really beautiful presentation, Dr. Domingo. So a quick question regarding for this reconstruction of these severely resorbed mandible. How do you decide on, we have FP3 versus a high water design? Thank you.
So for this, we do all that planning initially. I don't decide that after the implants have integrated. I actually decide that preoperatively. So for her particular case, through that big workup, we're going to create a new, as the amount of volume that we need to create for her, it was going to have to be 17 millimeters. We're going to have an FP3. Whether it's high water or not, typically you want them you don't want them high water where they get food underneath it, but you want to create a little bit of pressure on the soft tissue so they don't get food underneath it, but not so much pressure on the soft tissue that it creates a food trap and you get tissue inflammation. Keep in mind that that is not mucoperiosteal tissue. That's actually a free flap taken from the back of a right leg. So that tissue is not like the tissue that we're used to when we make an incision. It's much more vascular and it gets irritated. Think about like you get a splinter in your finger and the tissue expands and gets really inflamed. It's very similar. The tissue is very different. Thank you for the question.
Thank you.
Thank you for your excellent presentation and excellent cases, excellent results. So I'd like to ask a quick questions about the skin graft. I saw the skin graft on the top of the ridge. What did you do with that? You put the implant on top of the skin graft, or you did the like mucosal graft later on? Thank you.
So for these cases, they're very hard to augment. And if you're taking tissue from the palate, keep in mind, they remove the whole mandible. So the only way to get the primary closure by the oral surgeon is to take a free flap from the back of the leg. So anytime I do these cases, I'm never dealing with mucoperiosteal tissue. I'm always dealing with leg tissue. And a lot of times you'll see hair in patients' mouths and you have to, denucleate the hair. You can laser the hair off anyway, but it's different for the patients also because those tissues don't produce saliva and those tissues are typically dry. Right, and we don't think about that because the tongue's very wet, and once it touches that new alveolar tissue, it kind of sticks to it, right? So whenever I plan for these cases, I'll make a full thickness and reflection, and I'll push and try to extend the tissue out and place PRF over the ridge and try to get the tissue to heal by secondary intent. So I'm trying to open up and expand some of the keratin to try to create some type of hard tissue. I'm not going to get bound down keratinized tissue in that area, but I'm trying to get as best soft tissue profile, because honestly, to be able to take a soft tissue graft and graft this area, you're going to have to remove her whole hard palate. And the lady's been through enough surgeries as it is. So I've gotten good results with these cases whenever I keep my incision within that band of free flap tissue. Keep in mind, it's different. It doesn't approximate as well as mucoperiosteal tissue does, but it's better than movable mucosal tissue. If you have movable mucosal tissue around the implants, you have bone loss, and those leads to catastrophic failures. So I don't actually do any of the reconstructions anymore. I stopped that. I'll refer those out. Once they're completed, I'll let them heal for a year before they come in to see me for the reconstructions.
Thank you very much.
We'll get started. All right, let's start again. Good morning, good afternoon, and good evening to those of you who are joining us live online, and also to the judges of the MEGA'MIND. Thank you for joining me with me today here. Today, I'd like to share my story about how I discovered the socket shield technique as the ultimate and the best answer to the aesthetic buccal contour. Now, my name is Dr. Scott Jung, and I'm a dentist with a heart and passion for implant dentistry. I come from a beautiful city called Vancouver in Canada. And this is my clinic, Cloverdale Dental Center, where I eat, sleep, and perform dentistry every single day. Now, last year, I was very fortunate enough to make it to the last round of MEGA'MIND. And that experience really blew me away because I was able to meet all these clinicians from all over the world and learning and absorbing their knowledges and expertise. And that proved to be very invaluable to me. Now, and that was actually the reason why I was so hesitant to join this MEGA'MIND this year, because I knew the competition would be fierce and tough. But I know I had to join this because I know the last MEGA'MIND made me a better dentist who can serve my patients better. As the saying goes, what doesn't kill me can only make me stronger. So today, I'd like to start off my presentation with this particular picture. And this is a case that I did about 2 years ago. It's an immediate implant with immediate loading. And if you look carefully, you may notice something is a little bit off. Maybe you can see better in this view. Let me tell you this, immediate post-op, immediate 3 months post-op looked wonderful in my eyes. But after a year, after 2 years, this is what I see. The buccal contour has collapsed into a concavity. Now, how many of you have observed the same situation in your own cases? Or is it just me? Well, this is actually not uncommon. It has been reported in the literature many, many times. We know, despite the immediate implant placement, the labial palatal bone width still shrinks. And this one article, as an example, by Dr. Homely Wang, shows that resorption can occur up to about 18% within a short span of 12 months. And that's quite a lot. And so we begin to ask the question, why is this happening to us? Well, if you think biologically, it makes sense. As we all know, the alveolar process has 3 main blood supply. That is the periosteum, the periodontal ligaments, and the cancellous bone. Now, in the labial plate, especially the maxillary anterior area, where the labial plate is so thin, it doesn't really have a lot of cancellous bone to rely on. And so we cannot really rely on that blood supply. So for us, then, in order to place an implant, we remove the tooth, thereby removing the PDL blood supply as well. And now it becomes evident. With only the periosteum blood supply remaining, that is lack of blood that dooms that labial plate for resorption. So now, when I first got into immediate implant therapy, my hopes were filled. I thought placing the implant, filling the buccal jump gap, dual zone grafting would have saved my tissue volume and architecture. But truth was, this is what I see. The buccal contour still collapses. Now, thankfully, this patient has low lip line and is not complaining. The implant is still doing good and surviving. But in my eyes, I think this case could have been done better. And it's an aesthetic compromise, if not a risk for failure. So let's talk about the case of today. This is Dave, 67-year-old male with many dental history in his mouth. Medically, he's a little bit hypertensive, otherwise pretty healthy. And one day he visits me with a tooth in his hand. His lateral incisor post-core crown complex has broken out of his mouth. And as you would imagine, there really isn't much for us to save. He wanted his tooth back, so naturally, we began to talk about implant therapy as an option, and patient accepts. Great. Immediate implant, immediate loading, I've done this before, I got this in the bag, right? But that first picture that I showed starts to come into my mind, and I begin to ask that question, what if? What if the same thing occurs? What if the facial contour still collapses and patient starts to complain? I wanted to do the better for Dave. But Scott, So what if you have a little concavity, right? As long as the implant is fine, everything is good. It's good enough. But the thing is, I'm not happy with good enough. Now, once upon a time, our telephones actually looked like this. It's a dial-up. It's rudimentary, but it worked. And everyone was happy that they were able to call their grandmas 20 miles away and no complaining. But after a while, this phone turned into this, an iPhone with all the bells and whistles. How did that, a dial-up, transformed into an iPhone? Well, that's because there's always a small percentage of people who pushed for better, who seeked betterment. And those are the people who cut the cord from the dial-up, added a screen, pushing the boundary and bettering our world. I'm here to be better. Okay? I'm not happy with good enough because I don't want good enough in my mouth. I want the better and the best in my own mouth. And shouldn't we be treating our patients as if we should treat ourselves? So, how can I do a better, the best buccal aesthetic contour for Dave? Well, from what I know, there's two options available for us: connective tissue grafting and socket shield technique. Now, as we all know, traditionally, connective tissue grafting is used to improve the buccal tissue volume. And this is a case example that I did. Okay? If you look, you can, after the addition of CTG, the buccal tissue volume has improved dramatically. But what about socket shield technique? Well, the idea was, instead of adding something into there, what if we are able to preserve the labial plate as is? That would have been saving that blood supply, which comes from the PDL attached to the tooth. And it's showing a lot of promise. There are some more and more data is coming out, and this one particular article shows the 5-year, there was minimal to no changes in facial contour. So we have the CTG and socket shield. Which one's better for us? Well, there's actually, unfortunately, a lack of data comparing both methodologies directly. But there's this one case study that I found. And you can see on the right central incisor that received the socket shield technique shows very minimal changes, up to no changes at 12-month mark. Whereas the left central incisor, which received the CTG, is showing some negative changes highlighted in blue at 12-month mark. So we can see maybe the socket shield is a better thing. Well, that makes sense in my mind because I believe preservation is better than compensation. That's because CTG is ultimately a compensatory mechanism. The labial plate still remodels, but this adding a CTG compensates for its loss, whereas socket shield technique is 100% preservative. From what I know, replanting to regrow a forest is a lot more effort than keeping the forest alive. So let's go to our patient Dave again. We have a situation with a broken tooth, and we want to place an implant in here. Okay? But if we know that placing just the implant, we're going to lose all this beautiful buccal contour. So, is socket shield the answer for Dave? Well, let's look at this article together. And this article summarizes the indication and the contraindication of socket shield very, very well. Now, I don't have the time to go through every item here today. And so I'm going to show you the 3 main reasons why I chose the socket shield technique as answer for Dave. The tooth was non-mobile. There was no peri-involvement, and unlike CTG, there was no need for a secondary surgical site, reducing patients' morbidity. So let's begin with the socket shield. Now, socket shield technique is a technique-sensitive thing. Partial extraction has to be done to remove a portion of the tooth, leaving the space for implant. And the implant placement must be so precise, it does not disturb the shield, but also achieve a prosthetically ideal position. And to do all this in a small confined space like lateral incisor, wow, that's a tough job to do, right? But I know I wanted to provide the best for my patient, and I got the tools in order to achieve that. So we start with a challenge to remove a tooth, leaving a root tip inside. It's counterintuitive, but I confess, I have left root tips inside before, but it was never intentional like this. Okay, so in order to do this, we follow a certain protocol. And the protocol that I follow is by the PET kit from MEGA'MIND. And this kit has specific drills for partial extraction therapy. Now, as the literature recommendation we follow, we create the shield to create optimal stability. And crescent shaped in order to provide a maximal space for the implant. And we add an internal chamfer in creating a room for the tissue. And once it's created, this is what it looks like. And now it's time to place an implant. And in order to place an implant in a small, tight space like this, we need some help because one little slip and your osteotomy could be ruined. And so we utilize a guided surgery. R2Gate is my go-to. Digitally pre-planning allows us to calculate the exact position of the implant that's away from the shield and prosthetically ideal. And using the guide, we're able to perform the osteotomy and implant placement smoothly as possible. And this is what we end up with. Implant position well away from the shield in a prosthetically ideal space. And also 4 millimeters deep from the buccal margin in order to achieve zero bone loss concept. Now, to do all this perfectly, it took some time. Now, if we don't gain the initial stability here, all that becomes meaningless because we're not able to provide a tooth to our patient. That's what he wants, right? So to get that initial stability, not only does your surgical technique matters, but the implant design. And that's why we choose the blue diamond with the taper design and aggressive knife thread in order to gain that 45 newtons per centimeters. And this is what patient goes on with, a tooth in their mouth. Okay? Now, this immediate provisional was created using a 3D printed shell picked up intraorally on a temporary abutment with some flowable composite. Now, once it's picked up, a care must be taken care of in creating a proper emergence profile. The biological emergence profile is highlighted by this S-curve here. And if we don't do this, we would actually lose the tissue that we worked so hard to preserve. And this is the provisional in the mouth. And now notice the black triangle here. This is not a mistake because in about 2 weeks, you can already see the papilla filling in. And this is not magic. This is actually predictable because once we understand the Tarnow's rule if we create the contact point within the biological limits from the interproximal lawn, we know the papilla will fill in given the space. An X-ray also shows a stable bone level with the socket shield peeking behind it. 3 months later, and once we remove the temporary prosthesis, look at that tissue, right? It's ready for final prosthetic. No tissue sculpting is needed because we already spent the time to create a perfect emergence profile. Here's the final prosthetic created with the custom abutment with zirconia crown and the tooth inserted in his mouth. Beautiful, right? And from initial presentation to here. Now, when we overlap these images, you may notice and appreciate how well the buccal contour has been maintained over time. And I was able to recently meet Dave and was able to see his tooth just like this. And what we notice is that the buccal contour collapse has not yet been repeated for this patient. And the CT showing the buccal shield still holding up the labial plate as well. So I can attest to you today that I've done my best for Dave with the best tools and the best knowledges that I have access to. And as you can see, the socket shield technique is a lot of work and effort to put in just one tooth. And so you ask, why do we do this? Well, that's because this is what I would want in my own mouth, and I would do the same for my patient. Now, I like to end this poem with a short poem, end this presentation with a short poem. Good, better, best, never let it rest, till your good is better and your better is best. Each day, there's always something new and better. As a dentist, as a doctor, we spend the time to learn the better in order to provide the best treatment for our patients. Thank you for joining me in this presentation. Thank you so much.
Recording stopped.
Thank you very much. That's a nice
Thank you.
presentation. So I'd like to ask you, did you do any gap grafting for this case?
Yes.
Graft.
The small gap in the implant was filled with the allograft. I'm sorry?
So you prefer more allograft more than xenograft, is that right?
That's right. That's right.
So what do you think about other kind of materials, such as calcium phosphate or something?
Absolutely. I mean, there's nothing wrong with using a different material. There's always time and the situation for each material. In my cases, I mainly use allograft because what I want to do is, in order to create a quality natural bone, allograft seems to be the best result.
Okay, thank you.
You're welcome.
Thank you, Dr. Jung, for such a beautiful presentation. I would like to
Thanks
ask,
much.
for the soft tissue technique, what are the potential complications you could foresee, and how would you imagine managing that?
Absolutely.
Thank you.
There are some possible complications, such as early exposure of the shield. Okay, and also could be the socket shield eventually gets loose and mobile, which may poke through the shield later on as well, and also potential for infection around the shield as well, and plus all the other complication possible for immediate implant as well. There were a couple of times that I performed this surgery, and I had like early exposure of the shield, but very easily managed by just simply reducing the shield with the diamond burr under the gums. And I noticed that after about 2 to 3 weeks, the soft tissue fills in after that.
Thank you very much.
Okay.
You're welcome.
You have 15 minutes. If you are ready, please start.
Hello, everyone. Thank you for being here tonight. It's beautiful Sunday in Vancouver, Canada. And I would also like to welcome those who are joining online. Tonight, I would like to share our full arch implant treatment protocol called MKFP1, focusing on how to avoid transition line exposure in maxillary full arch implant treatment. My name is Paul Lee. I'm the director of full mouth implant prosthetic at Vancouver Chrysalis Dental Clinic in Canada. Let's begin by defining the transition line. It's a line between the implant prosthetic and adjacent soft tissue in maxillary full arch implant treatment. It's most noticeable in FP3 prosthetics. Oftentimes, it's not a big issue as it gets hidden under patient's lip. However, the transition line can be exposed in gummy smile patients as a result of improper treatment planning and inadequate surgical execution. So gummy smile can be caused by any of the factors listed here. It's usually seen in young female patients aged between 20 to 40, and it affects about 7 to 14% of general population. So what does literature say about avoiding transition line exposure in gummy smile patients? Botox can help by paralyzing the muscle. However, this is not a permanent solution. Surgical repositioning of the upper lip is an option, but this often yields unpredictable results, and it can cause unnatural smile line. More definitive treatment plan is to reduce bone sufficiently enough to place implant apically to hide the transition under the patient's lip, upper lip. While it seems logical, but in actual clinical setting, reducing bone in gummy smile patient can be quite challenging. Have a look at a patient's photo here up on this slide. Imagine how much bone we have to reduce to provide her with fixed maxillary full arch implant treatment. Thankfully, she did not require any full arch implant treatment. She just needed to have her failing upper right central replaced. Despite having a vertical root fracture in the central incisor, her thick gingival phenotype and interdental peak bone level were well favorable for immediate implant. According to Tarnow's rule of 4 millimeter, we can predictably maintain 4 millimeter papilla height from the crest of the bone to around the implant. And other extensive research supports the protocol for anterior immediate implant in a case like this. So for her, I performed a traumatic extraction following the protocol listed on the right-hand side, immediate implant placement with flapless, proper depth control at right position, and provided provisional restoration for her in attempt to preserve soft tissue and hard tissue as much as I can, and produce a beautiful final result like this. Even in the hands of novice surgeon like myself, we were able to preserve and recreate what was missing by performing minimally invasive immediate implant, even in gummy smile patient. If we know how to do this, why can we achieve same result in maxillary full arch implant treatment? What if we treat maxillary full arch implant treatment as if we're doing 2 immediate anteriors, 2 immediate premolars, 2 immediate molars, joined by pontics? By only replacing what is missing with the immediate implant and provisionalization, we can avoid transition line exposure, and this is the core concept of MKFP1. Not every patient can get FP1 treatment. Patients with severe ridge resorption or other anatomical limitation may not be suitable for this. However, for patients who are suitable to get MKFP1 treatment, it is the best way to avoid transition line in gummy smile patient with fixed full arch implant treatment. So what is MKFP1? MKFP1 is a philosophy and workflow created by Dr. Mark Bond and his team at Vancouver Dental Chrysalis Clinic. And it's minimally invasive, biologically driven, predictable full arch implant treatment. Tonight, I'll showcase MKFP1 is what MKFP1 is about by showing a case of young female patient with gummy smile. Meet Randy. Randy is a healthy 32-year-old patient whose chief concern is her failing teeth. She immigrated to Canada from Hong Kong, and with 2 children in a new country, in a busy life, she did not look after her teeth well. And her teeth were breaking constantly, and she lost hope in her teeth, and she lost confidence in her smile. After thorough examination, this is what we observed in Randy's mouth. I mean, we created problem list to come up with a treatment plan. There are so many things to go over, and as you can see, this is not a simple case. It's a very complex case, and her young age and her gummy smile makes matters even worse. However, Randy is a strong woman. She's raising 2 children, and she's determined to make positive changes in her life, and we wanted to help her best possible way. So our treatment plan was to replace posterior teeth in the lower with implants to create better function and improve her occlusal plane. And for maxilla, we decided to do fixed full arch implant treatment to replace compromised teeth and give her better aesthetics. Conventional all-on-X treatment requires significant bone reduction to hide the transition line. For young age, I wanted to preserve everything possible so that in case of future failure, she can deal with failure a lot better by preserving the bone and soft tissue. And thankfully, her interdental bone level was well maintained. And as we mentioned, Tarnow's 4mm rule, the rule gave me hope that this case we can do the MKFP1 treatment to preserve her soft tissue and hard tissue. And in terms of my prosthetic design, for maxillary fixed prosthetic design, I wanted to keep it as simple as possible. I wanted to avoid cantilever, and I wanted to provide her with 4 3-unit segmented bridges. By keeping it simple, these prosthetic implants can be repaired and replaced by any dentist if needed in the future. And because we're doing 4 3-unit segmented bridges on maxilla, that means in the maxilla we're placing not 4 implants, not 6 implants, but 8 implants and 3 implants in the mandible. To confirm if my prosthetic plan was even feasible or possible, we started doing digital wax up. Power of digital dentistry is that it allows us to see the future even before we start the treatment. It really empowers us to do prosthetically driven implant planning. And here we decided to increase her video by 2 millimeters to gain more prosthetic space and open up her bite. As Fabry reported in 2018, we can predictably increase video safely up to 5 millimeters in maxillary full arch implant treatment. And CBCT confirmed that her interdental bone level at the proposed implant site had a good bone level for immediate implant and for MKFP1 prosthetics. And as we finalize our prosthetic design, we were confident that our MKFP1 treatment would be a best option for Randy. However, in order for my prosthetic plan to become reality, my dream to come true, our surgical team had to place 11 immediate implants in a precise manner possible at the right location at proper depth control. And that is not easy thing for any surgeon out there. But thanks to advancement of digital dentistry, this is more predictable than ever. For precise prosthetic-driven implant placement, we use MegaGen's R2Gate software to fabricate tissue-borne surgical guide based on our prosthetic design. And on the day of the surgery, our surgical team led by Dr. Mark Won performed atraumatic extraction and no bone reduction for patients. The minimally invasive surgery is key for preserving tissue and for accurate fitting of tissue-borne guide. And with the help of tissue-borne guide, Dr. Kwan placed 8 implants on the top, 3 implants on the bottom, and patient went home with 5-millimeter tall healing abutments. And our dental lab team fabricated provisional restoration based on final implant position and prosthetic design. And we 3D printed our first provisional restoration for its efficiency, reproducibility, and accuracy. And patient came back the next day to receive her new teeth. And during this appointment, we established physiological and functional and repeatable occlusion with her new teeth and with her new video. And this is a panoramic image of provisional restoration and our implants. 2-week post-op, as you can see, her tissue is healing well and Randy's smile line is getting bigger. And 6 months post-op, hard tissue and soft tissue settled and remodeled around the provisional, and thankfully she's not having any issue with her new occlusion. And we transferred this information into digital form and created second provisional restoration to reflect tissue changes and include maxillary and mandibular molar implants. And here we milled our second provisional restoration with PMMA material to better capture her functional occlusion. And Randy tried these or used these second provisional restoration for 2 months, testing out her aesthetic, phonetic, occlusion, and function. And when we were all happy with the result, we went on and fabricated final prosthetics. For final prosthetic, we designed and built custom titanium abutment and zirconia restoration. For anterior area, we anodized our custom abutment to gold for better gingival aesthetics. And here are the beautiful photos of our final MKFP1 prosthetics. And we created 4 3-unit bridges for the maxilla, 3 single crowns for mandible. And these are custom hex titanium abutments. Those are engaging abutments. So you have to seat these abutments first in the mouth and cement those restorations intraorally to ensure passive fit. And the day of final delivery, it's a big celebration for us. And our CAD/CAM master, AJ Quintero, who designed and fabricated the final prosthetic, came to celebrate the glorious day with us. And the final intraoral photo. And look at that natural gingival contour that we were able to preserve. Final intraoral photos from occlusal view and the panoramic image showing impressive result. And we performed free gingival grafting to enhance keratinized tissue around maxillary posterior implants. 1-year follow-up. I'm very happy to report that Randy is maintaining her teeth well, keeping them clean and healthy. And she's not shy about showing her beautiful teeth with her natural smile line, which seems to be getting bigger and bigger. And this is 1-year follow-up panoramic image showing stable result. And if I were to show you our initial planning, if we were to superimpose those together, it shows how we were able to preserve her soft and hard tissue to create this beautiful result. My dream really came true here. So Randy's journey clearly demonstrates how MKFP1 can transform a smile. Although this is far from perfect solution for her, and some people may argue that pink porcelain would have given her better aesthetic, I truly believe that this MKFP1 is our best effort in providing our patient with minimally invasive, biologically driven, full arch implant treatment. We can offer this treatment for our patient with the terminal dentition to regain oral health, form and function, and confidence in smile. And remember, whether it's a gummy smile or challenging case, with the right approach, we can transform not just teeth but lives. And I would like to end in a And as Randy's smile grew bigger, so did her confidence and joy. Because in the end, it's not just about the implants we place, but lives we touch and the smiles we create, changing lives one smile at a time. Thank you for your attention.
Recording stopped.
Sorry, there was a little bit of a glitch at the end during my conclusion.
Okay. So any comments, any questions?
Dr. G, please start first.
Sure. Well, congratulations, Dr. Lee. Another very beautiful and touching presentation.
Thank you very much.
Yes, beautiful result too with the teamwork. How do you decide on the fixture level restoration versus an abutment level restoration? I guess you question quite often.
So for MKFP1, we do a fixture level. We try to avoid MUA, multi-unit abutments. Yeah. And that's usually in the plan. Because we try to place implant as straight as possible. We try to avoid angle implants. And with the fixture level implants, especially for MegaZen's anyone, it has 11-degree internal taper, which allows us about 20-degree of freedom in engaging the immediate temporization with non-hex cylinder. So that helps us to reduce chance of using abutment level connection,
Thank
for
you.
instance. Yeah.
Thank you. And Dr.
Thank you,
Bonkanchi?
thank you for the nice presentation. So I agree with
Thank you.
If the patient got the whole level and the gingival contour nicely before, that is better to preserve everything there. And for the immediate placement, the same question again. So for the gap grafting, which graft do you use and why?
That's a great question. So for grafting, for the full arch cases, our surgical team utilizes sticky bone. They follow Dr. Sohn's sticky bone protocol and mainly use allograft material.
Okay, thank you.
Thank you for your You have 15 minutes. So if you are ready, please start.
Yes. Hello, everyone, dear colleagues and friends. I hope everyone had a fantastic time presenting today for the second round of MEGA'MIND. You guys saved me for the very last. I hope I can be as amazing. I've watched every single presentation. Everyone was fantastic. So thank you, MEGA'MIND. Thank you, MEGAGen. And of course, thanks Mark Wan, Bytes Institute for this fun event and encouragement to participate this year. I'm super stoked for everyone and wishing everyone good luck. My name is Dmitriy Ivanov. I'm a board certified periodontist from Redondo Beach, California. My topic today will be on the tissue will always be an issue, especially with the management of complications. And we've seen a number of the complications today, which were beautifully managed. I want to just start with a famous quote by an American astronomer and scientist, Garrett Service. He said that science does not ostrich-like bury its head amidst perils and difficulties. It tries to see everything exactly as everything is. Simply put, if the surgeon says that he does not have complications in his practice, it's probably because he doesn't do enough surgery or he's lying to us. So I wanted to start with that. Sharing our own complications is something we learn from. Before we jump into talk about a case in clinical work, I would like to review a few basics. This concept of restoratively driven implant therapy, we all know what it is. It simply means that the case treatment planning should always start with an ideal restoration in our mind. And this concept is true across multiple modalities that we've seen today. Posterior teeth replacement of full mouth rehabilitation cases. It is especially important in the aesthetic zone where the room for error is so small. But to be able to practice this type of dentistry, we got to have good bone and good soft tissue. So before we get into before we are able to successfully develop hard and soft tissue case or procedure like what we just talked about, treatment planning and case selection is very important to us, which is a way of identifying specific risk factors. So a lot of risk factors, of course, are present. Again, we've seen many different risk factor discussions today. And understanding all possible risk factors is something that can make or break the case. And I think I want to make the presentation of my clinical case to kind of surrounding the thought of a variety of risk factors and how skipping on the risk factor evaluation can really break or make the case for us in the future. Some of the risk factors we obviously can modify. We can grow the bone predictably, we can grow soft tissue predictably, but if we have for example, a loss of attachment on an adjacent tooth, it is very hard to recover sometimes. And if an implant has to be placed next to it, it becomes a big challenge aesthetically as well as surgically. We can also sometimes, where we cannot, or also sometimes modify certain patient factors. For example, if patient smokes 2 packs a day, not willing to change, we can't do anything about it. Or patient that has been on IV bisphosphonates for a number of years. So certain things we have to be able to modify, certain things we have to be able to avoid. And let's jump and discuss our case. This is a 68-year-old male who was referred from a general dentist practice after a failure to extract the tooth. They were working very hard, broke a piece of the root that was left in place. Overall healthy patient, non-smoker, no history of periodontal disease, all probing depths under normal, no inflammation. Some poor plaque control since the extraction. They made him some sort of an Essex retainer to wear, so he wasn't able to manage this. But overall, pretty good, pretty well-maintained patient. The tooth was needing an extraction because of failed endodontic treatment. His chief complaint was, I would like to replace a missing tooth. So let's take a look at some of the risk factors. Obviously, we're deficient in a volume of bone. Volume of bone and soft tissue. We also have slight papilla loss and very much thinning of the papilla. There might have been some trauma. The big thing here to note is there's still a dehiscence, a probable dehiscence that leads into a piece of the root that you can still feel inside. So, and the patient has a pretty high smile line, which is fairly, on the aesthetic risk assessment, is a high risk patient for us. So generally speaking, in a case like this, I would treat this with just a conventional, basically the way I treat sockets with with the buccal bone missing. And this type of case, because the soft tissue overall quality was great, very good phenotype, nice zone of keratinized tissue, I didn't think much about this at first, especially the dehiscence that was present. So we removed the remaining root that was present. We cleaned the defect and we prepared it for just the conventional socket augmentation. There was a dehiscence, but it was very nice piece of bone that was still remaining there. We augmented the site. This was just augmented with a ridge augmentation type procedure using Os6 Plus membrane and glycolon internally stabilizing sutures. This is a mixture of autogenous bone with allograft in a sticky bone form, which was stabilized again internally with Os6 Plus membrane. And flap was advanced, nothing very out of ordinary, just a simple closure. The dehiscence was just approximated with the sutures. Again, I did not think much about anything that might go wrong because it was a very tension-free closure. I was not preparing for any complications, but 2 weeks later, unfortunately, we ran into a very big problem. Patient comes in, there is no pain, but we see a complete dehiscence of that distal area of the flap and complete loss of the papilla. This is the membrane that's exposed at this phase. We simply manage this non-surgically. We told the patient we will need to reevaluate since there is no infections. We manage this case every week to make sure that the patient is stable, and this is how we presented at 2 months. So basically, we starting with a new set of risk factors that we have to reevaluate, the more drastic risk factors, but nevertheless, we're at the drawing board again. Bone tissue deficiency. Now we have a bigger problem with the defect present on the root surface with the attachment loss on the facial and the proximal. We have thin tissue at the crest and again, high aesthetic risk. We have a higher smile line. So we have to plan for the next step. So we're going back to the drawing board and discussing option with the patient. Obviously, this tooth is very stable periodontally. It is not going to be needing an extraction. There's no mobility. A very long root. So we go over options with the patient and discuss the possibilities of future result. Basically, patient has to be let know that these type of defects may never end up ideal. And this patient was very realistic. He accepted the treatment plan with the notion there might be a need for a multiple soft tissue and bone augmentation procedures. So because of the attachment loss, we wanted to take advantage of possibly regenerating some of the attachment. We used a conventional GBR approach here and using a little bit of a GTR approach with some endogain application on the root surface. This is again Os6 Plus membrane stabilized with the glycolon sutures. But at this time, I was trying to omit or avoid the same complication that happened in the dehiscence. We decided to augment the soft tissue, both protecting the flap as well as starting to develop the soft tissue in the papilla area. This is a pedicle connective tissue graft, also known as a VIP CTG graft. Why did I choose that? Because that graft comes with the blood supply. It's the only graft that usually maintains the entirety of its volume during the healing process compared to like a free connective tissue graft, which tend to shrink to a certain degree. Our closure is very similar to a GBR approach. We are advancing tissue as coronal as possible. As you can see, I will show you how I stabilize these type of grafts internally in just a few seconds. I usually give this time at least 6 months to heal because that's how long it will take for the bone regeneration to happen. But at this point, we're going to ask ourselves a couple of questions. First, do we have enough bone? Well, we took a CT scan. We are going to take a look at it in a second. But the more important question is, how is our soft tissue? Well, if we take a closer look, there is still recession present on the tooth mesial line angle. There is still deficiency in the papilla area, although the defect had corrected quite a bit. So what I told the patient, we're going to place our implant because our bone is ready. We're going to open and take a look at it, but we're also going to be doing additional soft tissue augmentation using another VIP connective tissue graft. So we open our flap with the notion we're going to be designing our flap with the papilla in place and a full thickness on the site where we're going to be augmenting. We're going to place our implant 3 to 4 millimeters apical to the proposed gingival zenith for the emergence profile in a screw retained position. This is a great view to show the difference in the peaks of bone, which is why we have a defect there. The design was a full thickness up to the mucogingival junction and a split thickness right at the mucogingival junction to allow advancement of the flap, but also stabilization, which we will be using for additional grafting. This is a second VIP connective tissue graft, is a pedicle graft that came from just the local area. And this is addition of a tuberosity graft, a very thin layer that will create a very beautiful, thick gingival margin for the area of recession for the long-term maintenance. Both of these have been stabilized independently. I like to call this a scarf technique because the key to a VIP CTG, it has to hug the root of the tooth very, very nicely without any dead space right here. Then we advance the flap similarly to a GBR. This time we're going even more coronally because again, we're trying to get as much tissue height against the root as possible and to get that attachment level higher to regenerate the papilla. In these type of cases, 2 months is sufficient for the blood supply vascularization of this graft. So we are now 2 months into the healing of the implant and 2 months into the healing of the soft tissue. So we're now ready to start developing the tissue emergence profile with the temporary. I always temporize the aesthetic zone cases myself. We simply expose with the biopsy punch. I use a 15C blade to remove a small core of tissue and create a very narrow emergence profile. Subgingival contour has to be extremely narrow, not to put too much pressure laterally. We're only putting pressure in this critical zone to create adequate zenith position for the future restoration. But proximally, we want to leave as much space as possible, always leaving a lot of space. It appears that there's some push of the papilla apically. Not to worry, everything is very concave inside, so we should be able to recover that papilla. It's going to start growing. I also took advantage of that time formed after the surgery to kind of improve the aesthetics of the case. And we gave this time about 3 months, or this case about 3 months to mature. We took off the provisional at that time, and now we can really appreciate the soft tissue development. We can appreciate the width of a keratinized gingiva. We have a beautiful tissue in a horizontal connective tissue dimension and a vertical dimension. All of this I call a blueprint for an ideal restoration. We covered basically all bases. We have good bone, we have good soft tissue surrounding the implant. The implant is in the proper position, so we are ready to take a final impression. I always use a custom impression coping because I want to transfer the information that I've created for the soft tissue into the lab. When lab makes me a restoration, I do not want to see any more blanching because we're not changing position of the tissue at this time. This is the delivery on the final of the final visit. Let's look at the crestal bone level. Crestal bone level was very stable and aesthetics were quite good. Patient was extremely happy. He's been without a tooth for over 1 year and 3 months, or 1.5 years almost. This is a 1-year follow-up, 1 year and maybe a month. We just saw him 2 months ago for the recall. He's improved his oral hygiene overall. The tissue was quite stable, extremely functional, very nice contour of the restorations. Although we do have some soft tissue defect in approximately. The crestal bone level, this is an x-ray after 1 year of function, also quite good. Actually, there's some more notable cortication that was formed compared to the initial delivery of the prosthesis. So again, comparing the before and after, where we started with a big disaster to this full recovery, or at least a part of full recovery of the facial tissue and partial recovery of the papilla, patient again is extremely happy. This is the smile line, and we had a very challenging time matching the shade. As you can see, there's so many different chroma and shades and colors, but patient is extremely happy. Now that's what really mattered to us, that we were able to deliver. As final thoughts, treatment planning and case selection is always key. That's depending on your experience. ID every risk factor possible before starting the case, and do not ever hesitate to stage the case. As you can see here, one issue cover and heal for 2 months and then come back to do my bridge augmentation. I think we would have been in a much better situation without worrying the patient too much. In complicated cases, plan more but do less. And tissue training in the aesthetic zone is a must. We cannot bypass the provisualization of tissue in the aesthetic zone. It's just simply impossible to do. And then as a risk, if we do these type of cases, we have to assume a certain risk because complicated things will have more complications to deal with. We just have to be prepared for it. I wanted to thank everyone for your attention for these last 2.5 hours. You guys were listening to us speak. I wish everyone best of luck. If you have any questions, my contact information is my email here, and my Instagram account is Peri-implant_LA. Thank you.
Thank you very much.
Recording
for your
stopped.
Very nice presentation. So I agree with you that soft tissue will always is always an issue, especially in the complication case like you show us. And it's not problem for you. You are experts. You are a periodontist. You are experts in soft tissue management. That's a very nice case at the end. So I heard that you apply Emdogain as well in this case. So what do you believe in the effect of the Emdogain? Do you use it in most of the cases or not?
Emdogain to me is the last resort. You know, in the cases like this where you have a purely horizontal defect, is obviously not a very predictably regenerable defect. As we see, it's not an intrabony defect that we commonly treat with guided tissue regeneration and can be using Emdogain. I think those cases are more predictable. But in this case, this is what we call a Hail Mary. It's, the last resort kind of thing. I'm going to throw a kitchen sink at it in hopes that if I can gain some attachment back, a true attachment, if we can grow some bone back or some of the attachment apparatus back, we will have a better result than we started with, because we're starting very low. Right. So in this case, it is not something that I would use in every single case. Emdogain is not something I use in root coverage procedures. It's mostly used for procedures of regeneration, of guided tissue regeneration, if you have intrabony defects. So in this case, maybe the value of Emdogain was not extremely superior. It did not, I think, gain me a significant amount, but in sort of my hopes to get something back more than what I've lost because of the complication. That's why I decided to use Emdogain.
Okay, thank you very much.
Beautiful presentation, Dr. Ivanov. Okay, especially the soft tissue management, amazing. So let's say if I want to be, or if the patient were really picky and he was like, okay, I still have that 1 millimeter dark triangle over there. How would you discuss with the patient, or in other words, what are the limitations of your papilla regeneration, or is there any limit in your thought that, okay, that's it? Is there any limit for the numbers of surgeries, this and that, especially for soft tissue surgery?
That usually be a very good question. And this patient was one of those unicorn patients that do not commonly walk through the door and say, let's do 5 surgeries, unlimited amount of money, right? It's not the case. But this patient was very willing to do anything possible. So it really depends on the patient. This patient was not a picky patient, but if it was a patient that wanted more, I would most likely talk them out of it, because the limitation becomes a scar tissue. I will basically explain them the situation, that the number of surgeries and the number of time I enter the palate, then the more scarring we form. We would rather maybe control this slightly restoratively better, maybe put a veneer on the tooth next to it, like tooth number 10, or the lateral incisor, to widen the tooth and make it wider and bring the contact point down. Because doing another surgery, I can retract from the success of my second surgery, because I think we've stabilized the tissue quite well. And when I saw that, the limit to me is usually 2 surgeries. If I don't achieve the result that I want, I'm more willing to seek the help of a restorative dentist, either utilizing pink porcelain or using maybe a wider tooth to lower the contact. So my cutoff line is usually 2 procedures, and I will tell the patient we will do maximum 2 procedures. because in a case like this, I don't know what the limit might be physically. I've researched, I've read online of the amount of vertical connective tissue gain. I think 7-8 millimeters is a little pushing. If you think of where the CJ is versus where the bone level was. So I think 6 millimeters is my cutoff line to get the vertical soft tissue height. 6, maybe 7 millimeters. Above 8, I don't see how that's going to be long-term stable. Even if we gain 1 millimeter more with additional surgery, the maintenance of that extra, it's questionable still. So I will tell patients straight away, if we're quit at this point, if you're happy, will be less expensive, less surgery for you. But that's sort of my 2 surgeries, my cutoff line. About 8 millimeters is my maximum vertical height that I think, and it depends on the thickness of palate. This guy had the best palate that you can ask for 2 times. So yeah, that's basically my cutoff line. I don't have a firm number or the literature that supports the exact maximum. I've researched, I Googled it. If you have a suggestion, I will take the reference, please.
Yeah, that's very great answer. Thank you very much.
Thank you.
We need to balance the idealism and the reality too. Very nice.
Yes, thank you.
Okay.